This is Randy Schell, and I'm making a video cast on aging physiology and pharmacology. This video cast is part of the University of Kentucky College of Medicine Department of Anesthesiology didactic series. Let's first look at the aging physiology keywords from over the last decade published by the American Board of Anesthesiology. And these focus on the changes in the cardiovascular system, the central and autonomic nervous system, respiratory system, and some pharmacologic changes that occur with aging. On the bottom right in the blue box, the content outline published by the American Board of Anesthesia in 2018 on the topic geriatric anesthesia and aging is shown. These include physiologic implications of aging in the brain, the heart, the respiratory, renal, and hepatic systems, and some pharmacologic implications of aging, including changes in MAC with aging. If we look at first the cardiovascular physiology and aging topics, you can see there are multiple keywords related to cardiovascular physiologic changes, including changes in left ventricular function, diastolic dysfunction, increases in systemic vascular resistance, and in the brain there's changes such as autonomic dysfunction. There is a decrease in brain mass and cerebral blood flow and metabolism that we will touch on. In the respiratory system, there's a decrease in P-AO2 when we draw blood gases from elderly patients related to VQ mismatching and increases in closing capacity. There is pharmacologic changes, including sensitivity to opioids. There is sensitivity to many of our induction agents, our volatile agents, and there's newer medications like donepezil that can have anesthetic interactions that we will touch on. First of all, let's look at aging and perioperative services and recognize that there's more and more surgical procedures being done in the elderly, and that when you look at Medicare data, you can see that complications are occurring quite regularly related to anesthesia, surgery, and medical problems. And often we can't rescue these elderly patients from the problems that they're having in the perioperative period, and many of them are dying during that time. So it's important for us to understand the physiologic changes that occur with aging and design our anesthetics accordingly. If you look at age and anesthetic risk, advanced age is a consistent risk factor for morbidity and mortality associated with anesthesia. And we know that as we age, chronic diseases also increase. And it appears that the risk of anesthesia is more associated with coexisting diseases that are building up as we age rather than the aging process itself. And therefore, ASA physical status, let's say 3, 4, are better predictors rather than just chronologic age, where many of us recognize that an 80-year-old might have the body of a 40-year-old, while a 40-year-old can have the body of an 80-year-old. So it's coexisting diseases that seem most important for increasing risk. There's no evidence that age by itself increases perioperative risk in the absence of comorbid conditions. So is it an age-associated decline in physical status related to chronologic or biologic age? And if you look at this age-related decline in our ability to make our heart produce a higher cardiac output or a higher minute ventilation in the respiratory system, is it a problem just because we're getting older, or is it biologic aging? And we know that lifestyle habits and diet and psychosocial factors impact this physiologic decline that we can document in the older patients. Most importantly, however, it's this lack of functional reserve that they have, the inability to ramp up the cardiovascular system, to ramp up the respiratory system in the stress, in our case, of the perioperative period. But there is little correlation between chronologic age 70 or 80 or 85, and biologic age. So what really is important, if we look at this graphic, we can see that as we age, our basal metabolic rate, yes, decreases some, but the basal metabolic rate as well as the basal organ function decreases. But it's really that maximal rate. What can your heart do? What can your lungs do? And that maximal organ function goes down, and you can see it decreasing at age 60, 70, 80. And where the red star is, you can see that this functional reserve is much less than it was at 75-ish or 80 as related to the larger difference between basal and maximal rate at age 40. What this is saying is that the functional reserve of our body is not present as we age. We cannot ramp up the amount of cardiac output that we can produce from our heart or minute ventilation from our lungs like we could when we were 40 when we're under stress. So often in the preoperative period, we'll ask patients, what can you do? And we feel pretty comfortable when they can say, I can climb 2 flights of stairs when we ask them. And we know that 2 flights of stairs, the ability to climb them, correlates pretty good with about 4 mets or more, metabolic equivalents that is, where 1 metabolic equivalent is the ability to use 250 mils of oxygen a minute, which is a basal metabolic rate of our body. So if you can ramp it up to about 4 mets, we can say, well, they have a pretty good chance of getting through the perioperative period. There's something that has recently been identified as a risk factor in the perioperative period for aging patients, and that's frailty. Frailty is an extreme form of decreased reserve, limited ability to respond to stressors, and it's an independent predictor of mortality in the hospital. The phenotype, what it looks like of a frail person, is this clinical syndrome where there's a lot of weight loss, for example, in the last year. They say that they are exhausted, they can't grip very strong, they walk very slowly, they have low physical activity. And if they have 3 or more of these, we say this is the clinical syndrome of frailty. There's also frailty indexes that are out there where you can check boxes, yes or no, whether they have certain symptoms, signs, disease, or disabilities. And when you add them up, you can say this is their frailty index. Recognizing frailty in an elderly patient is important because this is saying that they have a very limited reserve to respond to the stressors of an operation, for example, and the mortality is higher. If we look at physiologic changes of aging, on the y-axis is percent change associated with age, and on the x-axis, age in years. If you look at the far top right, basal metabolic rate goes down with aging. Our maximal heart rate is approximately 220 minus our age, such that mine right now probably can only go up to about 160 or so, even if I exercise to my maximum. So 220 minus your age, your muscle strength goes down, your bones lose mineral mass, your cardiac output can't go up as high as it could when you were young, and your ability to use oxygen at your tissue level goes down. But our hearts get bigger and thicker and our blood pressure goes up. So let's focus on the heart first, the cardiovascular changes that occur with aging. And it's important to separate out the cardiovascular effects of aging versus common coexisting diseases like coronary artery disease and high blood pressure and diabetes. Atrial fibrillation is common, and the aortic valve getting calcified and sclerotic, and some form of aortic stenosis, mild, moderate, or severe occurring. There's an increased prevalence of cardiovascular disease with age. But the major changes that occur physiologically include 1, a decreased response to beta receptor stimulation. 2, their heart, veins, and arteries get stiff. And we normally think of the arteries getting stiff and blood pressure going up, but we often forget about the veins, the capacitance vessels of our body, and the heart itself getting stiff. The autonomic nervous system, the sympathetic system, cranks up while the parasympathetic goes down. And the conduction system of the heart has changes including fibrosis of the conduction system, and for example, right bundle branch block is pretty common in the elderly. Looking first at cardiovascular changes number 1, and then the effect on beta receptors. If you look at the top right, you can see norepinephrine attaching to beta 2, beta 1 receptors, and when they do so, chronotropy, dromotropy, inotropy, lusitropy can be affected in a positive way. Heart rate goes up, conduction is faster, heart beats stronger, heart relaxes more, actually. And in the elderly patient, they have a decrease in response to norepinephrine's effect at its receptor. this is not a downregulation of the beta receptor or a decrease in numbers of receptors. It's just that these little receptors don't work as well. The ones that are there, they don't couple as well from the norepinephrine binding to the receptor to all the things that have to occur in the cell for calcium to go up inside, for example. This coupling of binding to the receptor and then its effect is not as good, but the numbers of receptors do not go down. So there's a decrease in response to both endogenous, the circulating catecholamines, as well as what we administer exogenously. So we would not expect to have as great an effect from the same dose of epinephrine, for example, as a younger patient. Clinically, what happens is this elderly patient's body goes, wait a second here, if my beta receptors aren't working as well, the norepinephrine endogenous that I'm releasing isn't getting as much effect from the amount that I'm secreting, then I better crank it up a bit. And so circulating norepinephrine goes up, and if you measure it in the elderly, it'll be higher. When you need more output from your heart, the heart can't increase the heart rate as much. 220 minus our age, approximate maximal heart rate. Venous return, the veins are very stiff and can't contract as well. And so venous return is affected. And systolic blood pressure goes up from having stiff arteries. Decreased response to stress and exercise. When we need more cardiac output, our heart rate can't go up as high, and we meet demand as we age by that Frank Starling mechanism, basically, of preload reserve. So the heart's operating from a higher volume inside. Let's look next at stiffening of the cardiovascular system. The arteries and veins get very stiff, and the arteries get stiff, causing systolic hypertension. Commonly in the elderly, it's not uncommon to see systolic blood pressure of 170 and a diastolic pressure of 90 or 95. If the veins are stiff, there can be ineffective maintenance of preload. The veins are a reservoir for blood and can buffer changes in blood volume, so that if we lose blood during a surgery, the veins can contract and put more blood into the heart and to the body. And if there's a lot of volume in the body, the veins can relax and take up some of that blood. So they buffer changes in blood volume, and that just doesn't work as well in the elderly. Pulse pressure tends to widen in the elderly. So systolic minus diastolic pressure, instead of being, let's say, 120 minus 80 and a pulse pressure of 40, now it's 160 over 90 and a pulse pressure of 70. Afterload goes up, and the heart beating against an increased afterload thickens, and LV hypertrophy is very common, and systolic function at rest, often measured by ejection fraction, let's say 60-65% being normal, is usually normal in the elderly. But their heart gets very, very stiff, and diastolic dysfunction can occur. And as the heart gets stiff, they become more and more dependent on the filling of that heart from the atrial kick, staying in sinus rhythm, not going into a junctional rhythm or atrial fibrillation. They need that kick to fill that stiff left ventricle. They need time for filling of the left ventricle, so they don't tolerate the heart rate going up high very well. And if you pour in a bunch of fluids to an elderly patient into that stiff ventricle, you can imagine how the pressure will rise in that ventricle and could back up into the lungs and result in pulmonary edema. So if we move on to what happens graphically, we can see to the heart with volume changes and how cardiac output is maintained. If the peak heart rate can't be reached as high and we don't use oxygen as well, then how can we maintain cardiac output as we age? Well, the stroke volume goes up and the end diastolic volume goes up. So they're operating from higher volume hearts to maintain their cardiac output. And that's shown graphically on the far right, blue being the elderly, red being the young. And you can see that the elderly are operating from, on the x-axis, higher volumes to maintain the cardiac output, as opposed to increasing ejection fraction, for example, which would be another mechanism of increasing cardiac output. Diastolic versus systolic dysfunction, what's the difference between the two? If diastolic dysfunction is common in the elderly, and usually they maintain their systolic function, what's the difference? Well, diastolic dysfunction is shown graphically with that big, thick left ventricle, LV hypertrophy, and systolic dysfunction with this heart on the top right that's thinned out and would not be contracting well, maybe ejection fraction of 20, 25, 30%. And if you look at pressure volume curves, the bottom left shows a pressure volume curve of a patient with diastolic dysfunction. They operate from a little bit lower volumes, but definitely from a higher end diastolic volume and pressure. So the normal is shown in the light green, and normal left ventricular end diastolic pressure is shown where I'm pointing right now, and that is usually less than 18. And as the pressure rises in the heart during diastole, just before the left ventricle ejects, that's when it's full left ventricular end diastolic volume. If you trace it over at the time of left ventricular end diastolic volume to the pressure that's in the heart at that time, you can see that left ventricular end diastolic pressure can go up in that stiff left ventricle. And the patient with diastolic dysfunction, therefore, is at risk for several things. One, they're at risk for heart failure, and that's called heart failure with preserved ejection fraction as opposed to heart failure with decreased ejection fraction, which is systolic dysfunction. And so heart failure now, or congestive heart failure, is becoming much more common in the elderly patients related to diastolic dysfunction than it is with systolic dysfunction. That stiff left ventricle where the pressure's back up and the left atrium becomes big and often goes into atrial fibrillation as it stretches out and the pressure's back up into the lung and can cause pulmonary edema. Instead of treating this type of heart failure with diuretics and inotropes, classically diastolic problems of the heart are treated with beta blockers and calcium channel blockers. So diastolic relaxation is a problem in the elderly heart and can be often associated with atrial fibrillation, heart failure with preserved ejection fraction, and pulmonary edema. Some cardiovascular changes of the autonomic nervous system. When we're thinking of the autonomic nervous system, we can think of age-related changes and superimposed cardiovascular disease together. And trying to tease these out sometimes can be difficult. But cardiac output in general is preserved at rest. That is, if you measured cardiac output in a young person and an elderly patient, let's say 5 liters in the elderly, 5 liters in the young, doesn't change. Baseline cardiac output, baseline ejection fraction is usually the same in elderly versus young. But they have limited cardiac reserve. That is, the elderly patient cannot ramp up their cardiac output as much as the young person. And in the autonomic nervous system, the resting parasympathetic tone actually goes down, but the resting sympathetic tone goes up and is associated with high levels of norepinephrine, as we pointed out earlier, that norepinephrine goes to those beta receptors that don't work as well, and beta adrenergic receptor responsiveness is decreased, although their numbers are not changed, the receptor number themselves. The baroreceptors don't respond as well, and the elderly patient often has orthostatic hypotension, where your grandmother or grandmother may sit on the side of the bed for an extended period of time when they get up in the morning before they stand up, or else they might faint. So orthostasis is common. There is little change in the alpha receptors or muscarinic receptor activity, but the combination of these autonomic nervous system changes results in a decreased response to perioperative stress and impaired protective reflexes in response to hypotension. Again, looking at the autonomic nervous system, end organ responsiveness. The heart doesn't respond to the circulating catecholamines as much, and we said the norepinephrine levels go up dramatically, and beta agonist action will not be as great. So we're not going to get the same bang for the buck for a dose of a beta agonist. The chronotropic effects, the cardiac contractile effects, the vascular relaxation effects, for example, beta 2 receptor agonism, are not going to be as great. And the threshold for activation of afferent input to the autonomic nervous system goes up, and their baroreceptors are not as responsive. So when they get cold, they're not going to vasoconstrict as well. Their heart rate changes beat to beat are less because their autonomic nervous system is not working as well. And so they're going to have wider swings in hemodynamics. You don't get those train track blood pressure and heart rates on our anesthetic record quite as much. They're less effective in maintaining a constant organ perfusion, and they can get cold perioperatively more frequently. There's changes in the conduction system of the cardiovascular system also. The pacemaker cells decrease in number, so SA node dysfunction is common. Fibrous and fatty tissue can grow into the SA and AV node in the conduction system, such that sick sinus syndrome, nodal block, right bundle branch block, very common, and atrial fibrillation, quite common. And part of the reason for the atrial fibrillation is often diastolic dysfunction, where the pressures build up in the left ventricle during diastole, mitral valve is open during that time, and the atria sees that high pressure and dilates over time. And a big left atrium is associated with increased risk of atrial fibrillation. Increased ventricular ectopy also, but left bundle branch block, if you see that on an EKG, that is not normal aging and should prompt you to look for possibly ischemic heart disease. So some summary implications of cardiovascular changes with aging. One, we should identify concomitant cardiovascular disease like coronary disease and aortic sclerosis or aortic stenosis versus some normal aging effects. We should look for what the functional reserve of our patients are and try to identify whether they have frailty present. Large number of our patients will have normal preoperative electrocardiograms with increased cardiac dysrhythmias like atrial fibrillation, conduction abnormalities like right bundle branch block. Their systolic blood pressure is often increased and their pulse pressure wide. Their cardiac reserve is not as good. They have a stiff left ventricle, and heart failure with preserved ejection fraction is associated with that diastolic dysfunction. If we pour in fluids to these patients, it can lead to atrial fibrillation and pulmonary edema. And the elderly are going to act like they are beta blocked when we give them medicines that are beta agonists. Let's change to the respiratory system now and some of the changes with aging. The lung itself becomes more compliant with aging. You lose the ability of that balloon to collapse on itself. So when the lung blows up, there's less tendency for it to go back to its small size. So a decrease in lung elastic recoil is shown by this increase in lung compliance. So it's easier to blow open the lung, but the chest wall itself becomes stiff, often because of arthritis, cartilaginous changes of the lung. The oxygen diffusing capacity goes down. The closing capacity goes up such that their small airways are closing at normal tidal volumes, and there's VQ mismatching. And when you draw blood gas from an elderly patient, instead of having a PaO2 of 90, the PaO2 might be 70 in an older patient. That's normal for them. They have small airway closure and gas trapping, so that residual volume, air trapped in the lung, goes up, and they don't cough as well, and decreased expiratory flow rates on pulmonary function tests are an example of that. If you look at lung volumes on the y-axis and age on the x-axis graphically, you can see that as we go left to right from age 20 up to 80, that our total lung capacity is not changing much at all. And if you look at a tidal volume breath followed by a vital capacity breath, you can see that the gas that's left in the lung at the end of a normal tidal volume breath, which is FRC or functional residual capacity, is increasing. This is an increase in FRC with aging, that very compliant lung that doesn't want to collapse back. Closing volume, the gas that's in the lung at normal end tidal volume, and where it crosses the closing volume with the FRC. The closing volume crosses the FRC at age about 60, 65-ish or so, such that the small airways are closing even at normal tidal volume breaths, and so we're getting more and more VQ mismatch as we age. And residual volume is going up, so air trapped in the lung is going up with aging. So If we look at respiratory system and aging and break it down into the lung parenchyma and ventilatory control and respiratory bellows, the conducting airways and the airway reflexes, the lung parenchyma itself has a VQ mismatch and results in a decrease PaO2 from blood gases that we take from these elderly patients. They will have emphysema-like changes in that their lung is very compliant, doesn't want to collapse back to a small size, loss of elastance. The ventilatory control is not as good, and they're not going to respond to increases in CO2 with hyperventilation like you or I would, nor will they respond to decreases in oxygen like you or I would. So ventilatory control is decreased. The bellows, the chest wall is not as compliant. It's stiff, and they lose muscle so that they can't move their chest as much to get more air in and out, and their maximal minute ventilation will go down. There's minimal changes to the conductive airways, but the airway reflexes are decreased such that it's not uncommon when you do laryngoscopy in an elderly patient to see residual food stuck back around their glottic opening from meals that they've had more than 8 hours before. They have impaired ventilatory response to hypoxia and hypercapnia such that if you give them opioids or benzodiazepines or inhaled anesthetics in the perioperative period and they become hypoxic, they're not going to breathe as much, and they're not going to breathe as much to elevations in CO2. The VQ mismatch that occurs with aging results in a larger AA gradient and a lower resting PaO2. There may be a small left shift in the oxyhemoglobin dissociation curve or decreased P50 with aging. This doesn't seem to be a big factor of importance, but it was a key word from the ABA keywords published over the last decade, this P50 decrease. Hypoxic pulmonary vasoconstriction is also not as good, such that if an area of the lung is not being ventilated and the alveolus doesn't have as much oxygen in it, normally the blood vessels going past that alveolus should constrict and move blood to areas that of alveoli with good oxygen in them. Not very effective in the elderly compared to the young. So some anesthetic implications of the respiratory changes with aging. One, they're going to have a decreased ability to respond to hypercarbia or hypoxia. And the drugs that we give that are respiratory depressants in the pre- and postoperative and intraoperative period have a potential for increasing respiratory compromise. They're not going to, for example, in the recovery room, if you give them an opioid and it depresses the respiration, the CO2 goes up, they're not going to breathe as much. PaO2 is going to be lower preoperatively, and there's going to be greater decreases in the postoperative period, and their requirement for oxygen supplementation in recovery and in the operating room can be higher. And when you change them from standing or sitting to a supine position and give them a general anesthetic, VQ mismatch can be exaggerated even more and result in decreases in oxygen levels. What about the brain of the elderly? The graphic on the far right shows that there's a loss of cortical neuron density, loss of neurons, brain size decrease. As the neurons go down, their oxygen amount of oxygen used goes down, and if oxygen used goes down, which is CMRO2, cerebral metabolic rate for oxygen, then cerebral blood flow also goes down. So atrophy is frequent in the brain. This atrophy doesn't necessarily correlate with cognitive decline, but cognitive decline and dementia increases as we age. Blood flow goes down, cerebral metabolism goes down, but autoregulation is intact such that if you increase cerebral metabolism, cerebral blood flow will also go up in the brain. Or if you decrease cerebral metabolism, for example, with our anesthetic agents, cerebral blood flow will go down also. So autoregulation intact. One of the very important things in the brain is the effect of aging on neurotransmitters and receptors. Serotonin receptors go down, dopamine and dopamine receptors go down, acetylcholine and cholinergic receptors changes occur, and we think of Alzheimer's especially with these changes in cholinergic receptors. And the result of these neurotransmitter changes is an increased sensitivity to many of our anesthetic agents. And when we look at volatile anesthetics, there's a decrease in MAC of approximately 6% per decade or so after age 40. Postoperative dysfunction is not uncommon, and the difference between postoperative cognitive dysfunction and postoperative delirium is demonstrated here. Postoperative cognitive dysfunction is a persistent deterioration in mental performance by cognitive testing, and this is increased with advanced age. Advanced age is a predictor of postoperative cognitive dysfunction. Also, things like long operations and limited formal education and postoperative complications. Postoperative delirium is acute and transient. It's a clinical diagnosis, usually on the first or third postoperative day. And it's that classic patient who starts to get agitated, and as nighttime comes down, has sundowning. And as we stop often the polypharmacy, multiple drugs being given, and help them with their wake sleep cycles, get them out of the ICU, for example, the postoperative delirium goes away. So postoperative cognitive dysfunction, advanced age associated with it, is a persistent deterioration, while postoperative delirium is acute transient deterioration. If we look at the kidneys, like the brain, they lose cell mass. They lose glomeruli, they lose proximal tubules. And if they're losing glomeruli and tubules, their glomerular filtration rate goes down, and their ability to have the tubules do their function, like sodium and water exchange, goes down also. In fact, the Cockcroft-Gault equation, which is used to predict creatinine clearance, you can see that age is part of that, as well as weight and serum creatinine. As the glomeruli and tubule function decreases, their number goes down, they don't work as well, they can't concentrate and dilute as well, they can't handle sodium and potassium and hydrogen ion as well. And so when we have physiologic stresses in the perioperative period, they can be predisposed to prerenal azotemia, hyperkalemia, dilutional hyponatremia. They can't clear some of our anesthetic drugs as well. They often, in the preoperative period, will have pre-existing renal insufficiency that you don't even recognize because their serum creatinine looks normal. But if you see a serum creatinine that is at the high end of normal, let's say 1.2, 1.3, in an elderly patient who doesn't have much muscle mass, that implies a much greater decrement in renal function than a young person with a creatinine of 1.2. They can't dilute as well, and a greater urine volume will be necessary to excrete an obligatory solute load. So we have to be very careful with the fluids that we administer to an elderly patient, realizing that they can't handle sodium, potassium, hydrogen ion as well, and that the renal function is often decreased dramatically, even though the creatinine may be normal or near normal in the preoperative period. The liver also loses cells, becomes smaller, and hepatic blood flow goes down. It doesn't produce quite as much albumin, and the ability to perform oxidative phase 1 metabolism of drugs that we give patients in the perioperative period are also decreased. So drugs that have a high hepatic extraction ratio may have a higher concentration. The elimination of drugs that are metabolized mainly by the lung can have a prolonged, or mainly by the liver, can have a prolonged duration of effect. If albumin levels go down, and normally a drug that you give is bound to albumin, there may be more free fraction and more effect from that drug. But there tends to be little change in our standard liver function tests if we measure those preoperatively, like alkaline phosphatase and the transaminases. What about thermoregulation, or ability to maintain heat in the perioperative period? There's greater variability in core temperature with aging. There's no evidence that declining body temperature with advancing age in the healthy elderly in a thermoneutral environment occurs. That is, you don't just expect that just because they're aged, they should have a lower temperature. They just can't maintain their temperature as well, and they have a risk of hypothermia because, one, they can't vasoconstrict as well to cold. Their autonomic nervous system and their ability to sense and then cause constriction of blood vessels in response to the sensing of the cold. So attenuated vasoconstrictor response to cold. And when they're hot, they don't sweat as well. Their threshold for sweating goes up. So you can see why problems with temperature, usually cold, they get cold in the perioperative period, can occur. Pharmacologic changes with aging. Well, first of all, the body changes with aging. We lose muscle, so lean body mass goes down. We get more fat, and our total body water goes down, so you can see how drug distribution could be changed. Changes in volume of distribution of fat-soluble drugs. If we have more fat and we have a fat-soluble drug, there's bigger volume of distribution. If we have less body water and it is a water-soluble drug, it's going to have less space to go into. And the kidneys and liver don't work as well oftentimes. The liver and kidney lose cell mass, and if they're not working as well and our drugs have to go through either the liver or the kidney to be cleared, we may not clear them as rapidly. And elderly patients tend to be more sensitive to anesthetic agent. This is a pharmacodynamic effect, and they may have a hemodynamic response to drugs that is exaggerated. For example, when we give propofol as an induction agent to the elderly patient, like the young patient, they're going to vasodilate. Like the young patient, they can have some cardiodepression from the propofol, but propofol blocks the autonomic response, the baroreceptor response, the increase in heart rate that should normally occur, and it's going to do that even more in the elderly patient who already has not very well functioning autonomic system. So their blood pressure can drop even more with an equivalent dose of propofol than in a young patient. If we look at tissue changes and fat blood changes with aging, the fractional composition is on the y-axis in percent of body weight, and on x-axis is age between 20 and 80, and you can see that both in men and women, water is going down. Percent fractional composition of our bodies, amount of water, it goes down while fat goes up. Women more than men. And if our water is going down and our fat is going up, you could see how that the increased body fat can be a reservoir for lipid-soluble drugs. So the volume of distribution of lipid-soluble drugs goes up. There is also a decrease in serum proteins, albumin for example, and the binding of our drugs to those serum proteins can go down and more free drug can be available. And total body water goes down, and drugs that distribute to total body water, the water-soluble drugs, can have a volume of distribution that is lower. So if we look at comparing pharmacodynamics versus pharmacokinetics, pharmacodynamics, we're really talking about sensitivity and the effect of the drug on an organ, as opposed to pharmacokinetics, where we're talking how a drug gets into the body and out of the body. The brain is more sensitive to propofol and opioids and benzodiazepines and Sevo and Desflurane and Isoflurane, but there appears to be no central nervous system brain organ sensitivity increase with aging to barbiturates and etomidate, and our body, not our brain per se, but our muscles, to neuromuscular blockade. And in fact, with barbiturates, thiopental and Brevitol, you can see that it's not because the brain is more sensitive that we need to decrease the dose, but in the case of barbiturates, the drug goes up to the brain, there's a lower central volume of distribution. I like to think of it as just not leaving the brain as fast, and serum levels go up from higher serum levels result from a given dose in an older patient than in a younger patient. So it is a pharmacokinetic effect why we should reduce the dose in barbiturates, not the brain is more sensitive. But in general, most of our drugs, we talk about the brain being more sensitive to the effects. And so inhaled volatile anesthetics, the MAC is decreased significantly, 6% per decade after age 40. Induction agents, we usually decrease the dose somewhere up to 50% or so. It's not uncommon to be able to induce an elderly patient with propofol with less than 1 per kilo. Midazolam, probably should even avoid that in elderly patients, but when we use it, we decrease the dose quite dramatically. And opioids, about 50% decrement in dose, including remifentanil, because of this brain sensitivity. Neuromuscular blockers, it depends what we do with those. Number one, they don't have a change in pharmacodynamic sensitivity. The muscles are not more sensitive, but we don't clear the drug as well. In other words, the liver and the kidney cannot get rid of it as well. One exception to that is cisatracurium, which if you don't have a functioning liver or kidney, cisatracurium would be your neuromuscular blocker of choice. So there seems to be a benefit to choosing shorter acting neuromuscular blockers, especially in the elderly, and avoiding pancuronium because they have alterations in hepatic and renal clearance of the drugs. But it's not a pharmacodynamic sensitivity to neuromuscular blockers. Opioids in the elderly, there appears to be a decrease in pain perception and increased sensitivity to opioids, including morphine, sufentanil, fentanyl, and remifentanil, and we have a clearance that is decreased of these opioids also. We should avoid Meperidine in the elderly because of the delirium and confusion that can often result from its use. And remifentanil also has a brain sensitivity increase such that we should reduce it about in half, the bolus dose, and decrease even the infusion rates of remifentanil. What about our volatile anesthetics, such as Desflurane and Sevoflurane? A study some time ago now compared Desflurane and Sevoflurane in older patients undergoing hip or knee replacement. There was a little bit faster emergence and shorter recovery room length of stay with Desflurane. Cognitive impairment was about the same with Desflurane and Sevoflurane. There doesn't seem to be a big benefit to choose one of the volatile anesthetics, Des or Sevo, over the other. But there is worries about cognitive decline postoperatively in the elderly. More work needs to be done on this topic to help us choose whether we should be using one intravenous anesthetic, for example, or volatile anesthetic over another in the future. There are some select drugs and diseases that we should be aware of and their impact on the elderly. Meperidine or Demerol can cause postoperative delirium. Meperidine has an anticholinergic effect, and this may be part of the problem. Benadryl has a strong anticholinergic properties and can lead to delirium. We should avoid it in the elderly if possible. Scopolamine and atropine, you put a scopolamine patch in an elderly patient who we're treating for postoperative nausea and vomiting, and they can get delirium and confusion in the postoperative period more commonly than in the elderly. So the cholinergic system, if we manipulate it, we can result in problems in the elderly, specifically delirium and confusion. Benzodiazepines, diazepam has a very long half-life in the elderly. In fact, it can be estimated in hours by years in age of the patient. If an 80-year-old patient, half-life of diazepam about 80 hours, and you can see how if it takes 3 half-lives to get rid of a drug, how long diazepam could have an effect. And we avoid that in the elderly. They could fall more, have more confusion. Toradol, if their GFR is already down, giving Toradol, which blocks prostaglandins involved in renal blood flow. We need to be careful with nonsteroidals in the aged patient because there's a risk of renal injury. In Alzheimer's patients, some of those drugs that they take can interact with our anesthetics. Donepezil, or Aricept, another name for it, is a cholinesterase inhibitor. If it inhibits cholinesterase, it raises acetylcholine levels. Succinylcholine is broken down by a cholinesterase, pseudocholinesterase, and therefore donepezil or Aricept may prolong succinylcholine's effect. Memantine, or Namenda, another name for it, is an NMDA blocking agent. And remember that ketamine has an effect on the NMDA system. And there may be some interactions that we don't even know about and will be discovered in the future. Parkinson's disease, problem with dopamine, and if we don't have much dopamine in that Parkinson's patient, we block the dopamine receptor with drugs like Reglan and phenothiazines and Haldol. That patient may not be able to move and become akinetic. So in summary, we need to look at the coexisting diseases that the elderly patient have because this is the primary contributor to anesthetic risk rather than age. It's being old is not a contraindication to surgery. Having many coexisting diseases puts them at the highest risk. We need to look at their functional reserve. What can they do? Can they climb those 2 flights of stairs, do 4 METs of activity? Because it's the functional reserve that is impacted in the elderly. They have a diminished organ reserve, and it can be very unpredictable. And so trying to determine what their functional reserve is prior to surgery. Expect that there's going to be a lot of variability in elderly patients. Some 80-year-olds have the body of a 40-year-old. Some 40-year-olds have the body of an 80-year-old. And realize that the drugs that we give, the elderly are often more sensitive to them or cannot get rid of them as well. We expect perioperative blood pressure lability. Their sympathetic nervous system is ramped up and their norepinephrine levels are high, and they can have greater swings in systemic vascular resistance. Their baroreflexes don't work as well, and their heart rate can't get as high, and their myocardium can be very stiff and be dependent upon preload. So we don't expect to have quite those train tracks of blood pressure and heart rate in the perioperative period in the elderly patient. If we pour in fluids, that stiff left ventricle and those stiff veins can't take up the fluids as well, and the pressure can rise in the heart, and we can get heart failure and pulmonary edema and atrial fibrillation, a risk of excess volume in the perioperative period, especially in these elderly patients with stiff veins and stiff hearts. We should avoid certain drugs, things like scopolamine and Benadryl and Demerol and long-acting benzodiazepines, and avoid polypharmacy in the elderly. So if we look back at the key words over the last decade or more from the American Board of Anesthesia on aging, physiology, and pharmacology, under cardiovascular aging, you can see that LV function in the geriatric patient, systolic function is usually preserved, diastolic dysfunction, very common, systemic vascular resistance, we know, is increased. Under autonomic and central nervous system changes, the autonomic function is decreased, the baroreceptors don't work as well, aging is a predictor of postoperative cognitive decline, and under the respiratory system, we know that P50 shifts to the left maybe a little bit, but oxygen levels go down in the blood, resting PaO2, hypoxemia is more common as the closing capacity increases, FRC also increases, but these cross at age about 65. And under muscle relaxants in pharmacology, we know that their muscles are not more sensitive to muscle relaxants, but they may not clear those muscle relaxants as well. They are more sensitive to opioids, and they're more sensitive to other drugs, such as induction agents such as propofol and benzodiazepines, but they're not more sensitive to thiopental, which the reason why we reduce the dose is a pharmacokinetic effect rather than an increased brain sensitivity effect. And there is a MAC reduction in the elderly, and we know that they decrease the number of neurons with aging, and I like to think of it as the number of neurons going down. We don't have as many neurons to put to sleep, and therefore MAC goes down. Really, it is more associated with changes in neural receptors, such as acetylcholine receptors and probably GABA receptors and many other receptors in the brain, serotonin, etc., that results in some of these MAC changes. Donepezil is a specific drug used in Alzheimer's patients that may interact with our succinylcholine administration because donepezil is an inhibitor of acetylcholinesterase activity and raises acetylcholine levels in the brain of the Alzheimer's patient. But if it inhibits cholinesterase in the breakdown of succinylcholine could last longer. This ends this video cast on aging physiology and pharmacology, and I hope you have a wonderful day.